This program is brought to you by Emory University.
Hello, good morning, everyone, and hope everybody had a nice weekend. Today, it is my pleasure to introduce Dr. Clements, who I have had the pleasure to introduce several times in this conference, and he really needs no introduction. Dr. Clements is the R. Harold Harrison Chair and Professor in Cardiology and Director of the Echo Lab here at Emory. Over his more than 50 years, I believe, at Emory, he's received numerous awards and honors, many teaching awards, such as the Lifetime Achievement Award from the Georgia ACC, Patient's Choice Awards, many teaching awards. And more recently, O. Wayne Rollins Foundation established an endowed chair in Rollins School of Public Health in Dr. Clements' name. Dr. Clements has a passion for teaching at the bedside and physical exam, including EKGs and echoes. And today he's going to share with us, I wish I had known this a long time ago, and some images to remember. Thank you, Dr. Clements.
Thank you, Pooja. So through the years, I have shared these images with some of you, and I wanted to share them with all of you because they taught me so much. So I have no disclosures. So a picture's worth 1,000 words. Imagine yourself having somebody describing a coronary arteriogram to you, and you want to see the picture so much. I mean, it lacks something like the report. When you have a patient come to clinic and you only have the report, you're wanting to see the images. So a picture's worth 1,000 words, and a movie's worth 1,000 pictures. And it has been said that a minute's worth of video is worth 1 million words. So pass your own judgment on that. So to get started, I wanted to show this image. And I've shown it before around, and it's a very unusual image. And Chris, where'd Chris go?
So you want to fix the lights?
Yep.
I can do that.
Good. I mean, the lights compete with the image. So it's harder to ask questions when you have, when you do it on Zoom. I like it. This is an unusual image. So if anybody has any idea what this is, write it down in your minds and think about it. Maybe you'd like to see another view. Obviously, the right ventricle is dilated, implying that maybe pulmonary hypertension is present. That's part of the physiology of what's going on here. So I assume nobody knows what this is. So what would you do if you saw this? Would you call the surgeon as soon as possible? Would you think about catheter-based therapy? Would you do medical therapy? Would you do catheter-based therapy and medical therapy? Would you consider euthanasia? That's some clues.
You should call your veterinary cardiologist.
So we decided to do number 4. I actually was not in on that decision. Catheter-based therapy and medical therapy. And here's the catheter-based therapy. It goes the catheter down in the right ventricle, takes a big snip. It looks like we're doing a heart biopsy, although those forceps are larger than the usual forceps we do heart biopsies with. So when we pull it out, we pull out this large entangled mass of heartworms. And in dogs, this is called the cable syndrome. And the best thing to do is to pull them out and do the best you can with medical therapy. And obviously, if you give medical therapy to a dog with that many heartworms and you kill them, then they're going to embolize to the lungs and all kinds of distress might occur. So make sure you give your dogs their heartworm medicine. So I will show you this patient that walked into my office in the fall. And she was a 55-year-old lady who's a clinical psychologist at the VA hospital. So she'd gone somewhere to get a COVID vaccine and somebody checked her pulse and says, your pulse is too slow. So on the referral, it says, referred by so-and-so for a slow pulse. Now, this is a very common thing. And you know about it, but I want you to look at it a little different way. So here's the EKG that was run in the clinic. And as you see by Gemini, you diagnose this on the phone sometimes. And you say, well, by Gemini is probably present, have them come in and do an EKG. So by Gemini is present, sinus rhythm. A few things are notable about this. The P waves in lead 2 look a little peaked. So, well, I wonder, is the right atrium enlarged? The electrical axis of those extra beats, and that's what I want you to remember, is remember to look at the electrical axis. And if you look in lead V1, they have a kind of left bundle branch block pattern. So I've drawn the vector for you down there. Now the EP guys speak in a different language about this. They don't talk in terms of where the vector is. They talk in terms of the transition zone. And I'll show you that in a moment. So it's a decision times. What you do you put them on metoprolol? Do you start sotalol? Do you send them to the front desk and say, sign them up with the next available appointment with EP? Do you put a Holter monitor on and see what the PVC burden is? In that EKG, the PVC burden was 50%. You put them on the treadmill, you put the EKG in your pocket and show it to a friend. So we chose to do an echo to start metoprolol. Here we are starting metoprolol for someone who was sent in for bradycardia. We put on a monitor. We didn't do the treadmill right then. We did put the EKG in the pocket and showed it to a friend to see if that friend agreed. We did an echo, and the echo does not look normal. She had extra beats during the echo. And that ejection fraction is not normal. So we showed it to a friend. The friend agreed that these had a certain origin and agreed to have her back in the EP lab to study these extra beats. And we started metoprolol, put the tracer in the pocket, talked with a friend, and she came back to 4COA to have her procedure and had another EKG and had the same ectopic beats. They have that vector that I showed down toward lead 2 and posteriorly. And the echo at that time looked worse, and she was having shortness of breath. So she went to the EP lab to map where these were coming from. And what I wanted to show you this for is because I wanted you to recognize that these beats are coming from the right ventricle. In particular, they're coming from the right ventricular outflow tract. So you probably know about these, but too often I think we let them go and don't pay much attention to them. They can harm the heart, and there is such a thing as cardiomyopathy of ventricular ectopic beats. So these came from the RVOT, and they have a left bundle branch block pattern, as you see in the top tracing there and in the lower tracing. Actually, this man came to my office also, and we plugged him up to the EKG, and he just had runs of these everywhere. Sometimes it'd fill the whole 12-lead EKG. They're obviously coming from the left ventricle. I knew him, and I knew he had a ventricular aneurysm. And that requires some special attention. So these come from the right ventricular outflow tract. The EP guys make a big deal out of the transition. The later the transition, if there's vectors like that, in the precordial leads as compared with the normal beats, the more anterior it is, the more likely it's coming from the RVOT. And the earlier the transition, the more likely it's coming from some posterior location like the LVOT. So she was developing right in front of our eyes the cardiomyopathy of premature ventricular complexes. And she was getting in trouble. Now, I can't tell you that she didn't have an underlying cardiomyopathy also in the background developing, but I can tell you that it seemed to me that these extra beats cause whatever the mechanism of this is to become active and caused her ejection fraction to start dropping. So after the ablation, we eliminated them. That's not a perfectly normal EKG, but it's better than it was from the standpoint of arrhythmia. And her echo looks a lot better. And she's been repeatedly calling my office, asking if she can get off the beta blocker. And I said, nope. And anyway, that's a scenario that I learned a lot from. And in this conference before, I've shown people who have RVOT ventricular tachycardia and taken this step one step further. But here is RVOT ventricular ectopic beats. So look for them. You might they might be more important than you think. So this gentleman came to my clinic one day, and the nurse practitioner that was there that day went in and saw him first. And he came out, or she came out, and she told me something. So the question is, what did she tell me? And something about the physical examination. So this resulted in going to the cath lab. And this is what we saw. Now, I have to admit, I have trimmed this image. Just look at that. You know, if you're injecting the left and you have a mammary, you inject really hard, the mammary will fill to some degree, or you'll see evidence of the mammary being present. You'll see washout in the LAD. So, well, we know the mammary is present. Oh, you see the LAD is missing, and you know the mammary is present. So when you're looking at an arteriogram and you're trying to decide about whether or not the grafts are patent, and you see a dimple down in the MOM being tethered up like that, you know there's been a graft there. If it doesn't wash up in it, that's one way you size up where your grafts have been. So I tell you, this should provoke a certain thought with you when you see this. And I say, I have trimmed this. And, beg pardon? I trimmed it. So now I'm going to untrim it. So would you like to see a little panning? Oh, here you go. So a little panning shows that that mammary has retrograde flow. And it goes all the way up, and that shadow you see up at the top is not the mammary. That is the vertebral. Over to the right, you see the little turn, hairpin turn in the vertebral there. And so here we are injecting the left coronary artery, filling the mammary. The mammary goes all the way up, fills the vertebral transiently. And you say, well, what does this mean? So we'll get to that in a minute. The blood pressure cuffs, you can't always find them. So this shows you a little better about that little hairpin curve up there where the vert is. So what did the nurse practitioner tell me? Now, if you're accustomed to looking at carotids, you know that when you have your transducer oriented appropriately and you're pointing medially, you are looking for red. You're looking for red. That is, you're looking for flow coming toward the transducer or coming down. And if you see blue, that means it's in the vertebral artery, it's going in the wrong direction. So the answer is in the carotid. And if you're looking at carotids in a patient that's supposed to have a cabbage next day, then you need to call the surgeon and say, watch out for that, using that left mammary, because it's not worth taking down at this point. So I asked the cardiac fellows whether or not they've ever gone and watched a mammary being taken down, and you say they will usually say no, which means that if you think about a mammary taken down, you imagine some little artery going down like that with a bulldog clamp on it. Well, it looks like a little strand of fat because they don't strip the vessel all the way down to the adventitia. Looks like a little strand of fat. When they sew it in, if you look at operations, it looks like a strand of fat being shown into the LAD. So this is a red flag situation on the carotid ultrasound that tells you what's going on here. So what injection would you like to see next? You'd like to see this injection. And when you see that, if you look up there, you'll notice there's a flash of the first branch going up, and that's a vert, splashing up, and that's getting washed out. Thyrocervical trunk is next. The first downward branch is the IMA. It's not present. Over to the right, if you're not totally familiar with that anatomy, that's the way it goes. The mammary is not even feeling. If you look carefully for a washout from the mammary, it's not totally clear, but you see the vert washing into the vert there. So that's what you see in the cath lab. So how would you treat the angina with these medications, or would you do something like this? If you'll watch this one carefully, you'll see flow going up the carotid and vertebral system, and it's coming down the left vertebral and all the way to the subclavian. And when you see it come down on the right lower picture, the blue area indicates the mammary. You can see the mammary, or you don't see the mammary, and you see the arm taking away the blood. So what do? You stent that subclavian on the right, and you see the mammary reappears, and the vertebral appears with flow as it should be. So what did the nurse practitioner tell me when she came out of the door? She said the blood pressure in the left arm is much lower than the blood pressure in the right arm. So this is a subclavian steal syndrome, as you know by now. So especially in your coronary bypass patients, you ought to take the blood pressure in both arms. This was first described in 1960. So you all recognize that immediately. I'm proud of you. So the next question is, how does cancer cause cyanosis? Now, I can tell you that in the last 6 months, I've had a person come to the clinic, and without anybody telling me, I looked down at the saturations, and the SATs were reported as 89%. So I'd known this person before, and COVID had intervened, and the saturations in the past were in the 90s. So, But this is another patient that presented with O2 sats in the 80s. So if you see this ultrasound, you see something unusual on the right side. It's not totally defined. It intermittently bounces through the tricuspid valve. It's oscillating in the right atrium. Maybe you'd like to see some more views. The left upper one is the one you've seen. I mean, left lower one is one you've seen. The left upper one you see. Sometimes it always sticks its head into the RBOT. Something large in the right atrium, and it's going through the tricuspid valve. And the question was about cyanosis. So how might this present as cyanosis and an O2 sat at 85? So is the answer in this image? You have to look at it a moment. If you look down to the bottom left, you see the tricuspid valve and the mass bouncing against the tricuspid valve. If you look up at the top, see the superior vena cava coming in the area of the foramen ovale, the fossa ovalis. It gives rise to the foramen ovale. So what's going on here, and how does this somehow present as systemic desaturation? Well, if you look at that, you see the mass bouncing down against, you've already seen it bouncing through the tricuspid valve. And that, of course, increases right atrial pressure. That, of course, causes the interatrial septum to bulge to the right. And that, of course, if a PFO is present, tends to open it up. So you can think about that physiology. You also have to think of where in the world might this be coming from, and you always have to search for that. And you always have to look in the IVC, and this is where that mass was coming from. The IVC was full of tumor, and this actually was a melanoma. So going back to the question, why the cyanosis? When the tumor mass bounces down through the tricuspid valve and obstructs it, see that little red stream up there going through the PFO and circling around in the left atrium, shooting blue blood over to the red blood side and causing the cyanosis. So that is how right atrial masses produce cyanosis. So what else might cause this kind of physiology? So this lady, many years ago, actually presented with saturations in the 85% range. And you think about this kind of physiology, you think about Eisenmenger physiology. She didn't have any congenital heart disease identified early in her life. So she developed this later on in her life. So my question in this one is, as you look at it, is the right atrium large? You know, you're accustomed to looking at 4-chamber views, and you know, right is over here and left is over there. So you say, is the right atrium large? Then you get a little confused because not exactly sure what is what here. So if that's not the right atrium, what is it? And what are the things that might mimic or might fill up the right atrium? I can tell you that one thing that can do it is an aneurysm of the interatrial septum that can bulge way into the right atrium, fill it up. You've seen masses that filled it up. But this entity can fill it up also. So we know from the saturations that there's probably a right atrial shunt. So you're in the echo lab, patient has an IV, so what do you do? So let's do a bubble study for this large right atrium. So we shake up the saline, inject the bubble study, and the right atrium fills up, as does the right ventricle, and the left atrium and left ventricle fill up. And there's a filling defect in the right atrium. It looks like somebody blew a balloon up in there. So we know that's not possible. So if you watch this carefully, you'll see that after a period of time, that fills up with microbubbles. So it looks like that might be coming off the left circulation. I can tell you that coronary aneurysms sometimes can be so big they can change the size of the right atrium. And this entity can also. So maybe you already know what this is. So what would you like to do next? So let's do an aortogram. So we do an aortogram to see what's going on the left side. We see this large balloon-like area that's coming off that cusp over there, and it's really gotten large. How in the world did it get large like that without rupturing? Well, some do. And this is, by now you know what this is. They come in a lot of forms, and they are a result of a weakness right there at the point where the black arrow is. The junction between the aortic media and the annulus fibrosus, and that dilates down, and depending on where it does it, will determine where these things go. So that was the sinus of Valsalva aneurysm. And I said they come in a lot of forms. If you look at this picture on the left lower, you'll think that the patient has mitral regurgitation. That's not right. The one above that is the one that we just saw, can push on the coronary arteries, is in the right lower one, can push on a lot of things and compromise their function. So sinus of Valsalva aneurysm. So remember that when you see something in the right atrium, I think it's in the right atrium, it has several possible etiologies. And go search hard for where it might come. Like the one on the right in the cath lab was having a right heart cath, and the catheter went to the right atrium, things stopped. So in general in the cath lab, when something stops, it's good to kind of let a little whiff of contrast go in to see what might be there. And that's what happened on the right. On the left is one of the sinus of Valsalva aneurysms where the catheter slid by it and superior vena cava injection was made. So let's switch to the left side, and we'll follow the same principles. You always have to look for the origin. And the lessons to be learned. In the left upper picture, you see that myxoma pulling on the interatrial septum, indicating that it's attached there. The left lower the same way. The left lower one was a Delta pilot who just got off his plane and came in. You can see that on 3D in the center, and you see that vena cava is clear, and you see the right upper one that looks like a Cookie Monster. So always make sure the vena cava is clear. There are various ways you can diagnose these. I've never had anybody come up to me and say they diagnosed one with a coronary arteriogram, although we published this little paper about it. And it can be on the right or left. The one on the left is coming off the right coronary artery. The one on the right is coming off the right coronary artery. The one on the left coming off the left coronary artery. The one in the center corresponds to this myxoma just above that. And if you do a MUGA scan that we used to do for chemotherapy, you might see there's a filling defect up there in the right atrium. So they come in different forms. They many times are found on CT scans. Nowadays, and you're all up to date on it, so you say, well, I've got this down. This must be a myxoma. What about the inferior vena cava? Okay, you look at the inferior vena cava in this middle picture here. See, the vena cava is full of tumor. When you see that, you most likely think that's coming from the kidney. The left lower picture describes shows a big kidney tumor, and that's it in the center there. And if you've never seen a clear cell before, there's a clear cell. That's why they call this clear cell carcinoma. So that's the classic one that does it, but it can come from other places, including the liver, the adrenal gland, and even the uterus sometimes. And then you say you've got it figured out. I know how to do this. And one Friday afternoon, this young man comes in after having a little TIA. And you get all excited because he's already embolized. You call the surgeon. The surgeon says, send him to the operating room, calls the team and starts opening the chest and gets in there, opens the left atrium. And then you get the call, say, this was not a myxoma. Did not come from the interatrial septum. Came from a pulmonary vein. And the frozen section showed it was a sarcoma. CTA at the left lower image shows it coming from a pulmonary vein. So lung cancers, sarcomas grow in through pulmonary veins, and you have to carefully look at them. On transthoracic, of course, you can only see usually the right upper pulmonary vein. On transesophageal, you can see all of them, of course. And this angry tumor has been plaguing this young man since then. He's still with us, but it's been a struggle. So the next patient I want to show you is someone that, a young lady, and it reminds me of the stories that were told 2 weeks ago at Grand Rounds here. So this was a 28-year-old lady who had been told she had mitral valve prolapse. She did well, not known to have any arrhythmias. She was at a bar in Thomasville and playing darts, had 2 beers, walked out the door, was followed by a friend who happened to be an EMT, and just collapsed, fell flat on her face. So the friend started CPR immediately, called 911, paramedics came, between there in the ICU. She was shocked once. So she gets in the ICU in Thomasville, and the intensivist there did a great job of cooling her down and putting her on the ventilator. And it so happened that I knew her grandfather, and he had my cell number. And he called me up and said, my granddaughter is in the hospital on the ventilator in Thomasville, and we want her moved to Emory. So I said, okay, I will try. So I go through, you know what, and try to get that done and moving people around, and we got her up here. And we did note when I listened to her heart that she had a mid to late systolic click and a faint systolic murmur. She'd been cooled down. And by the time she got up here, she actually was coming around a little bit. So pressors were tapered off, cooling blanket was taken off. The next thing I know, she was awake and she was texting on the ventilator. So that's a new indication for extubation, texting on the ventilator. So our troponins went up a little bit. While she was here, she did not have any VT. So she had an echo. Her EKG looked pretty good. She had an echo that showed this. And there's something a little unusual down there where the posterior leaflet attaches to what should be the upper part of the septum. So part of the workup was down in that area, something a little unusual there. A little late systolic remember, mitral valve prolapse. And the MRI showed that same thing, almost like the posterior leaflet is attached to the atrial wall there, high up. And in this syndrome, if that distance is 10 millimeters or more, this qualifies for this syndrome, which is called the MAD syndrome, mitral annular disjunction syndrome. And it's been associated with all kinds of arrhythmias and sudden death. So the presenter 2 weeks ago mentioned that as a cause of sudden death in young people. We know mitral valve prolapse can be also. So what do you do at this point? Give her some antiarrhythmic medication. She's 28 years old. You put her in a device. What kind of device would you put her in? Think about what you might do with that. You know, if you put an intravascular device in, it's there for the rest of her life. And so how do you deal with that? Well, Mike Lloyd came up with a solution. He put a ICD in, and he put a subcutaneous ICD in. And you see it over on her left chest there is subcutaneous. And a few of these have been put in around here, and a few have been put in the country. There's been a proposal to put them in under the sternum. This is the first one I've really seen, but sounds like a good idea not to have to change devices and extract leads in the future. So I've not heard that she's had any shocks, but that's a sequence of events that happened in this remarkable young woman. So she had the MAD syndrome. So another situation we've encountered recently is this one. Now look at that a moment, and it's kind of a disturbing image. This man had bacteremia. Actually, the story was he came to our emergency room because he needed a TAVR, and at Piedmont they couldn't get to him for several weeks, so started going from one emergency room to the other. So you see the aortic valve opening there and closing, and you see the space above, actually posterior tube on the screen. It's above the aorta. It has maybe a septation in it. There are a couple of little defects there in the middle of that, seemingly connecting it to the aorta, another one down at the aortic annulus. And you first see that, and it's kind of a image that gets your attention, makes you stop and think a minute and say, well, what do I do next? So what do you do next? So let's push the color button and see what happens with those two images. Now, this is a study in Pisa. You know, if water goes down the drain, it goes down when it gets close to the opening, it goes down in hemispheric circles of velocity. And if you use pulse wave Doppler, which color Doppler is, and you change that aliasing limit, you can create a hemisphere there, and you know the transition from the blue to the yellow there is the transition where the velocity is, whatever that setting is on the left. So that allows you to use the surface area of a hemisphere and that velocity to calculate the flow at that level, and to identify that there is flow. And, you know, 2 pi r squared is a surface area of a hemisphere. So that times the velocity gives you the flow. But you can use the presence of that phenomenon in order to identify where flow is. So when you look at this image, you say, well, how many of those Pisas do you see? And this is going fast, so it's hard to see. So I see 1, 2, 3, at least 3 there. There's one systolic, one over to the left. And there are two diastolic ones over to the right. And the lower one obviously is flow going from the aorta into that cavity. And the other one is the pisa going from the cavity back into the aorta. I'm going to go back to show you that one more time. If you look at that now, your eye might catch it. So blood is going out the aortic valve. And it's coming back in from the cavity, going back into the cavity, one back-to-back pieces, and then the one that just defined there, the flat one, is flow into the cavity from the aorta. So there are at least three, and they tell us a little bit about it. So if you put your continuous wave Doppler through that, you see that what appears to be aortic regurgitation and diastole there and systole might give you the impression that aortic regurgitation is present. So how much aortic regurgitation do you see? And the answer is not really any under that valve. It's all coming back into the ventricle from that cavity. And that cavity is full of thrombi and bacteria. So once you get your eyes attuned to it, you can see where the flow goes and see all three of those pieces, and it tells you a little bit about how the flow is going. Not much aortic regurgitation is present, and this entity occurs when you disrupt the mitral aortic continuity there, and blood goes around the aortic valve, out into the aorta, and then back. And it creates a very difficult surgical situation when you interfere with the mitral aortic continuity and causes you to think about commando procedures and those kind of things. So blood's going out that way and back in that way. And very disturbing situation. This is called I call it a PMAF, pseudoaneurysm of the mitral aortic intervalvular fibrosa. And our patient had this one. We've had one patient here in the past who had one of the B varieties up there that was associated with a prosthetic valve surgery and actually was not associated with infection. And a vascular plug was put in there and we plugged it up, did not have to have surgery. So PMAF, pseudoaneurysm of the mitral aortic intervalve, is part of endocarditis, and sometimes it occurs spontaneously. So here's how it starts. So here's a bicuspid valve. Look over the right, you can tell it's a bicuspid valve. And something's going on at the mitral aortic connection there, and it's bulging out. And this is what we look for with endocarditis and valve ring abscess. And this is how those PMAFs start, and they either progressively enlarge or disrupt something, rupture, or what have you, cause the aortic valve to leak even more. And another situation, which is a bit puzzling, try not to look at that mitral vegetation. But if you notice that in systole, the aortic graft, this is an ascending aortic graft, the aortic graft is collapsing in systole. And that's not right. So why would it be doing that? I mean, I looked at this a number of times. Why is that doing that? It's supposed to be doing just the opposite. In systole, it tends to collapse. The aortic valve's opening too. So interesting 3D image when you, in 2D images, you see that large vegetation. You know what it is immediately. In this 3D image, you have to look hard to see it, but once you get your eyes on it, you see it. Just behind that is that expanding mass, expanding cavity back of. So the reason that's expanding is because it's pressurized, and there is an aneurysm back there of the mitral aortic intervalvular fibrosa. And that's why that aortic graft is collapsing in systole. So that's what I call PMAF. And you've seen the extremes of it. The mitral aortic connection, the curtain area is a delicate area. When it gets involved, you have to do surgery. It's a challenge for the surgeon. So today you've seen RVOT VPBs, subclavian steel, bedside, non-pulmonary causes of cyanosis, myxomas, not to be confused with other tumors coming up the vena cava, the MAD syndrome, and PMAF. Thank you. You all knew the answers to all those, I'm sure.
New one.
Elena knew all of them.
Put that mad thing back up.
Yeah. Which one? The echo or the MRI?
The MRI.
Yep.
All right, so this has become defined as MAD because of the distance of the above the prolapse above the annulus. What's the actual
Yeah.
definition?
It's the distance between the top of the myocardium up to the attachment of the posterior leaflet, which is actually on the septum there. I mean, on the wall of the atrium.
So that thing at the bottom right of that ventricle is the papillary muscle.
Yep.
And focusing on the annulus, but that papillary muscle is moving up with systole, and it's getting stretched out and pulled up by that prolapsing valve due to the cords attached to it. And I'm wondering if they did a EP study on this patient to figure out what the site of the arrhythmia was. You said it was this arrhythmia a inferior left ventricular origin arrhythmia? Did we ever get the
don't
arrhythmia
know.
nailed down?
No.
Never, because it didn't have consistent PVCs or anything, but you know what I'm talking about.
Yep.
The series of cases that we need Woody Cobbs to come back, and he would argue that this is a traction on that papillary apparatus that may have created fibrosis in there and that may be the origin of that. And this led in past time to replace with intractable ventricular arrhythmias, led to replacement of the mitral valve to try to solve that. And when the mitral valve is replaced in such a case, you see that area that looks hypercontractile becomes the opposite, becomes aneurysmal, because that's a damaged fibrotic zone. But
So some of those patients, as you know, Spencer, in that posterolateral wall there kind of gets buckled in by all the tension on that papillary muscle. And there's a lot of tension on that papillary muscle, those cords anyway. And it reminds me of a patient one time that had a mitral valve replaced. And that there was so much tension on that papillary muscle that it ruptured and it was just floating around in the breeze. And that was a result of problems with the wall that occurred in that series of patients that we had way back, in which we didn't have enough protection there, and that area either split open or it didn't move. So that area catches a lot, both from the papillary muscle tugging on it, and you can see that it's almost everted sometimes. You can see that also in looking at at one of the little branches of the circumflex artery that Spencer and Woody showed, and the artery would go from crinkled up to darting straight, right? Did you call that the dart sign? No. Anyway, that's a special area That's a special area of the heart. Woody Spencer described that. Andy?
So Steve, what I like about your talk is it helps us look at data and information. And, one of the things that you would think sort of absolute are numbers, but numbers aren't, right? So we have patients who have these watches at home that tell them what their heart rate is, or they take their blood pressure on the thing and they call you up and tell you they have a heart rate of 40, but they don't. We have nurses that record the heart rate of 85 out on the telemetry units. But they're on the patient's heart rate's actually 110 because they have a pulse deficit, because they have atrial fibrillation. I liked your what you showed with the right ventricular dysfunction. I'll ask students and residents, which in pulmonary hypertension, which is a worse number, having a PA pressure of 90/60 or 50/30. And the answer is it depends on what the right atrial pressure is, because as the right ventricle fails, the pulmonary artery pressure comes down. And then just a final comment about the subclavian steel situation is that we do occasionally see patients where they have chest pain, they get the nuclear scan done or the PET scan, and it shows, quote, ischemia, and they had previous bypass surgery. And then they get a cath, and the cath shows the grafts are patent. But then later somebody has to go back and take the blood pressure and remember to shoot to determine if there's a subclavian blockage there. So one of the fun things about cardiology is just correlating things and asking why the data doesn't fit the clinical scenario and thinking through that.
Great, thanks. Okay, thank you all.
Great. Thank you, everyone, for joining. And don't forget to get your CME credit. And I'll see you next week. Thanks.
Steve?
Hey,
Hey, Steve, are you still
Hey.
there?
yes.
It's Peter Block.
Hi, Peter.
Steve, just a comment on that mitral valve that's stuck up on the atrial wall.
Yeah.
That's one of those reasons you can't forget these folks, even though you may make them better, because one of the issues about them is if this is one of the strange kinds of situations where if the left atrium enlarges because the MR may get a little bit worse, but not symptomatic. Actually, what happens then is that the mitral regurgitation really can become severe. And this is mitral regurgitation caused not by ventricular problems, but by atrial enlargement. Sort of an interesting twist on what can produce MR. Because what happens is the base of that mitral posterior leaflet usually gets pulled backwards, and then there's probably free MR if it gets bad enough.
That's exactly
That
right.
makes sense?
Thanks. I agree with that. Okay, thank you all.
The preceding program is copyrighted by Emory University.